All right. Good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. This morning, we have pharmacy lightning rounds where our audience members have submitted their pharmacology questions over the past week. And to answer those questions to the best of our ability with the evidence that actually exists, we have our spectacular pharmacy guru, Peter, who is a clinical pharmacy specialist in oncology with Advocate Aurora. Today's format will be pretty straightforward. We're just going to try to answer as many questions as we can in a short and sweet style, probably 20, 30 minutes. So sit back and enjoy, and the floor is yours, Peter.
Thanks, Marty. As Marty said, my specialty is oncology, so a lot of my experience come with cancer patients. So please keep that in mind as I'm answering some of these questions. And as he said as well, sometimes there is not great evidence-based medicine behind some of what I'll be presenting today because there just isn't any. But I'll share my experience with patients that I've been involved with, and we'll go from there. This is definitely an open discussion for sure as well. Just because I have a certain opinion, and in some cases it's just an opinion on something, that doesn't necessarily mean there are not multiple ways to approach that question. So just some caveats there for today. All right, so make sure it advances. Okay, so first one is I was asked to describe the ideal buprenorphine patch patient. Who's the ideal patient to start on a buprenorphine patch? This is partially from the package insert that is out there and supportive literature that's out there. I've listened to podcasts as well where they've given some really good information on this. From my perspective, a chronic pain patient for sure. This is not something you're starting for acute short-term pain. This is a chronic pain patient. But with the, I would say, lowish opioid needs, I mean, we've really found that in very few patients, perhaps in severe cancer, we should be really escalating the opiate doses. But in a lot of other patients, we found that that's really not the best strategy anyway. So I feel like there's lots of a large patient population with chronic pain that could benefit from beginning with a buprenorphine patch, but not those who are like already on thousands of MMEs. I don't think that's a good approach to go. One of the things that's been reported over and over is that the buprenorphine patch tends to have less overall opiate side effects than some other opiates. So to me, that means, patients who are already suffering from issues with constipation, patients who are already having issues with other common opiate adverse effects, that might be a good option there for those folks. Also, patients with previous opioid use disorder issues. So these are patients who are not currently on any other meds, such as buprenorphine or methadone for opioid use disorder. But perhaps they had a history of it. And by history, I mean they definitely were using inappropriately in the past. It could be a good option in those patients as well. There is some literature to support that patients do a little bit better on buprenorphine due to the fact that it has not as many effects on that part of the brain that may give them that push to take it and abuse it. And one of the things I wanted to address with this question is constantly you read in the labeling in the United States for buprenorphine, oh, there's this QT prolongation issue. Oh, you shouldn't use it in patients with cardiac arrhythmias. My personal opinion is that's way overblown. In Europe, the labeling for these patches, you can go much higher doses. They've shown with good literature to support going to those much higher doses without any arrhythmia issues. So I truly believe this is a bit of a overstretch in the US labeling. However, it is there. They don't want you going above 20 microgram per hour patch at a time. But I'm just throwing it out there. I think it's definitely safe to go above that And it's very clear that other parts of the world are doing it. If you have any questions or anything, throw them in the chat or comments on any of these, and we'll address them towards the end. I'm going to try to speed up a little quicker so we can get through everything today as well. All right, so question about antidepressants and stimulants on pre and post solid organ transplant patients. Always concerns about drug interactions, other issues there. I did find one actual guideline on this. This is from the Academy of Consultation Liaison Psychiatry. So this is a group that specializes in consulting inpatient on patients with complex medical conditions. Their recommended is they had escitalopram, sertraline, and mirtazapine as their top choices due to limited drug interactions with immunosuppressive meds and the fact that they just preferred those particular drugs in other patient groups as well. They tend to have fewer side effects and just seem to work well overall in their expert opinion. As far as fatigue, not really great literature anywhere. This was a discussion we had at Aurora St. Luke's, and we all kind of agreed that it was very reasonable to do a trial of Ritalin for sure, to see if that helped. There was no real reason or contraindication in this particular population to not try it. So no great literature, but I think you can easily approach these patients a lot more similar to other patient groups, despite their immunosuppressive meds they might be on in the future. There is some good literature to support that the better the patients are before transplant, the better outcomes after as well. All right, so got a question about evidence behind not starting a patient on a fentanyl 12.5 microgram patch. So I think the question was actually, if a patient's opioid naive, I've heard you shouldn't start them on a 12.5 microgram patch. In a majority of patients, will this cause any severe respiratory depression or other major adverse effects? Probably not. However, it is very clear in the FDA labeling and in guidelines out there that fentanyl patches are not for opioid naive patients. So that's really where that comes from. I have seen it done. I have not seen any major adverse effects from starting a patient who's opioid naive on the patch, especially when other routes of administration just weren't options for those particular patients, particularly in post bone marrow transplant patients. I've seen it. Severe mucositis, severe pain from there. I think we're moving towards buprenorphine patches though in those patients instead of fentanyl patches like we used to, as we're convincing those doctors that that's a good option. But that is where that comes from. It is very clear in the FDA labeling and the guidelines not to do it. And I would truly recommend other options first, including a buprenorphine patch. All right, mirtazapine starting dose. Got some questions where they said, I usually like to start 7.5. However, I've seen a lot of people start 15 and say you need to start at 15. So where this really comes from is the dosing for depression and anxiety. It's very clear in the FDA labeling that they recommend starting at 15 and then titrating up to 30 and 45 for the treatment of anxiety and depression. Oftentimes, we're using mirtazapine in the palliative setting as a sleep aid or perhaps as an appetite stimulant as well, or an anti-nausea medication. So in those cases, at least in my experience, some patients have done very well with assisting in those symptoms at a 7.5 milligram dose. And there is pretty good literature to state that those higher doses aren't really well tolerated in those that are older or have more comorbid conditions. So I think especially you have to make it patient specific. There are some patients who can definitely start at 15 and tolerate it just fine. And again, that recommendation kind of comes from the anxiety depression. But If I tend to be more conservative, so I tend to recommend 7.5, especially if you're doing sleep and appetite as your major reasons to start the medication, or as a adjunct because they have some anxiety and depression, but not, not necessarily maybe have that be your primary med for it. All right, itching. I got a question. Well, how, that seems to be the trickiest symptom. How should we approach this? And it is tough. And there's not good literature necessarily. And really it's the what's causing it can be so varied. And how you approach it really hits what the underlying cause is. One of the things that I've learned in my work and that I've read as well is that antihistamines don't work as great as we thought necessarily in a lot of different types of itching. And they're not necessarily the ones you want to use. They're still considered one of the first line options in most cases, for sure. I personally like cetirizine as a second generation, give it just once or twice a day. I know the labeling only says once a day. But I think you can escalate the dose a little there, especially in severe issues. Have had some success, and I've had patients who haven't responded to it at all. That's been my experience with it. Lots of patients just don't take great care of their skin sometimes too, and that can be issues. Obviously the aggravating factors, and then help with alleviating factors. Good moisture, if they have really dry skin, good moisture control and those sorts of things are very important. And opioid induced, when I looked around, and what I've done is just change the opiate to try to a different class if you can, if that's happening. It's a known possible adverse effect of those agents. You can try topical steroids and antihistamines if it's localized. I mean, obviously, if it's everywhere, full systemic, then that's not as helpful. There is a little bit of literature to support using small doses of naloxone in opioid induced as well. I just wanted to throw it out there. It's not much. There's not good evidence behind it, but just wanted to throw it out there. You'd have to find a compounding pharmacy who can make the small doses to help with that, but it's there. The usual recommendations for cholestatic with ursodiol and cholestyramine. Please, if you have any good solutions you've run into in your practice, throw them in the chat, please. And then just some other agents to try in refractory I threw at the end here. There's either small studies or just case reports to support any of these agents that could possibly be used as well. All right. Are there any new meds for delirium or difficult behaviors out there? No, there really aren't. Most of the clinical trials out there are on behavioral interventions at this time, and or they use traditional meds we're already using in this space. Okay, I got a question about the platinum drug shortage. I'm actually our main person dealing with it at my organization. And it's due to generic drugs. The manufacturers aren't making a lot of money off of them, and due to profit pushes, they keep their margins very slim. So we had one manufacturer who had all of their lines shut down on both cisplatin and carboplatin, and they supported a large portion of the US market. That put pressure on all the other manufacturers who couldn't really ramp up production very fast at all. And we just don't have enough out there because of that one manufacturer shutting down, basically. That's the reason behind it. All right, neuropathic pain patient who's already on an SSRI, and I really want to start an SNRI to try to help with the neuropathic pain. Questions I always recommend asking these patients, how long have they been on the SSRI and is it helping? Is it making a difference? Sometimes patients just aren't honest with their doctors who are prescribing it, and it hasn't been doing anything for them, or they've been on it for 10 years and they're like, I don't even know why I'm still on it. Those are reasonable questions to ask these patients. and see if they're open to trying and transitioning to a different agent. What is the dose of the SSRI? I've seen so many patients who are on like 25 or 50 milligrams of sertraline or 10 milligrams of fluoxetine for like 5-6 years. And really at those lower doses, you're not actually treating. I mean, the studies behind these meds are in major depressive episodes you're titrating to higher doses. So they're not even being used where they've shown any benefit in those cases. And it's more, honestly, it's more of a placebo at that point. And it's, again, it's been proven in those mild to moderate depressive or anxiety states, behavioral therapy is really the key. It's not the drugs. The drugs really don't do much. And then is pain involved in the depression and anxiety where you would want to change anyway? You would want to do an agent that could possibly hit both of them for you. So this is very much a generalization that I recommend, and there are certain specific drug recommendations as well that are out there. But my approach is you could definitely start a lower dose of the SNRI at the same time you start decreasing the dose of the SSRI. This kind of helps to replace kind of the serotonin imbalances that are happening. And then on a weekly basis, you just move yourself down and you adjust if they have any withdrawal symptoms or any concerns. I have had really good success. I haven't heard of many issues utilizing this approach. This is an approach that is out there in the literature as well. Another option that I've seen used is sometimes providers will utilize fluoxetine as kind of a preventative med. They'll just stop the SSRI, give them a couple of doses of fluoxetine, and it has such a long half-life, it helps to block those withdrawal symptoms that a patient might have. So even just a couple of doses of 10 or 20 milligrams can do the trick to help prevent withdrawal symptoms in those situations. All right, is morphine the best option for air hunger? Was a question that we received, and I would say that it's the most used, and it's the one with the most literature behind it. Other opiates probably have similar mechanisms and probably could work as well too. But one of the benefits of morphine here is it has so many different formulations, and you can really use low doses of morphine here. You can use the liquid formulation, get down to smaller doses, and they can generally work well for air hunger if you don't have, and you can't necessarily get down at those really, like an equivalent dose to like morphine 2, if you think about it with hydromorphone, is like 5/100ths of a milligram almost. I mean, it's hard to get down and measure those amounts. So I think morphine also, just for delivery and ability to get to the doses you actually really need for this indication, is just an easier agent. However, if a patient is already on an alternative, going up slightly on the dose to try to assist with air hunger is an approach that I have heard about and seen as well. All right, I got a question about compounded drug combos for neuropathic localized pain. A particular patient was a vulvar cancer patient who was receiving a mixture of ketamine, clonidine, and something. There was another compound in there, and I apologize, I forgot exactly what was in there. But these are used in quite a few different neuropathic pain syndromes now. And there is some literature to support these compounded products. A lot of them have ketamine, clonidine, and doxepin in them. And what you need to do is compounding pharmacy has kind of become a real specialty, and there are pharmacies and pharmacists that really specialize in these particular compounds these days. At my organization, we actually have a compounding pharmacy, and what they do, and I know that Walgreens and CVS and some of the larger chains has this too, they'll make the compounds at that centralized location, then ship them out to the store that's close to the patient. So it's a matter of working with the patient's pharmacy to see if that's an option for them, or else asking them to go to a chain or a system that would offer those sorts of products. And they work. I have seen them work in patients. Sometimes they don't always work. And the other thing you have to be cautious with is the gels and the various things that these are compounded with can be quite expensive products, and the insurance copays can be high. So I highly recommend, before having somebody compound it all up, have them check to see how much the patient is going to pay and if they're willing to pay it. All right, question, seeing a lot of rifaximin for hepatic encephalopathy and really causing copay issues in the outpatient setting for patients. Not a lot of great literature out there for treatment of hepatic encephalopathy. Lactulose is definitely first-line agent, but it certainly has more adverse effects and more issues and is more unpleasant to take than taking those oral non-absorbing antibiotics like rifaximin. So that's why a lot of providers move that direction. However, truly, lactulose is kind of the standard of care. It's there's no evidence looking at comparing really any agent to another one in hepatic encephalopathy. One of the things when I was researching this is there is some literature to support probiotics as well as in this space. And there's literature to say that it can be beneficial. So that may be a cheaper alternative in some settings to the prescription oral antibiotics if the patient can't pay for them and they need extra support beyond lactulose, or they're not being able to tolerate lactulose. So just wanted to throw that out there. All right, and then last slide that I had was on the home hospice setting. Question on patient without intravenous access and suffering from seizures in the home hospice setting. What's the first options there? And what are options for like opioid allergies? And I have to be honest, one of the questions I really couldn't answer, so I just thought I'd throw it out there to the group here as well. This is not a setting I've treated a lot of patients in over my career, so it's not one that I am an expert in at all. But when I asked some experts about it, they suggested that lorazepam, either IM or sub-Q, would be an option, or diazepam IM. For seizures in these sorts of cases. It's not as quick acting as IV, but it's the best option for a patient who does not have that IV access, and obviously suffering from a seizure wouldn't be able to take anything orally in that setting. Generally, for active seizure patients, doses I've seen are 2 milligrams of lorazepam and 10 milligrams of diazepam. And a question came on a codeine anaphylaxis reaction. I know our symptom relief kits generally have morphine at a lot of institutions. You know, if you change to hydromorphone, the question was, what other medication should accompany the symptom relief kit if you change the morphine to hydromorphone? And that is a question I wasn't able to answer. And we weren't sure exactly what the question was getting at, but I thought I'd just throw it out to the group. And then this is our last slide. So if folks want to, if we want to bring up some of the chat comments, then Marty as well.
Okay, hello, thank you. Excellent presentation. Thoughts on methadone for air hunger?
I have seen it used in my practice a couple times. I think with the kind of quicker onset that methadone does offer, I think it's a reasonable option. I wouldn't consider it a first line option personally at this point. I don't have enough experience using it for that symptom to definitely use it there. I know in our inpatient hospice setting that we have at my organization, it has been used for that indication, as well as to transition patients off of There are other meds. Because of that, again, quick onset, you can give, an extra 2.5 milligrams of methadone with each dose safely to help treat air hunger as well. Again, I don't have a lot of experience, but I know it definitely has been done at our institution here, and it's been successful based off of my conversations with my partners there.
Lovely. All right. Thank you, Peter. We really appreciate all your knowledge today.
Great. Thanks for having me. Appreciate it.
Absolutely. Have a great weekend, everybody.